Good
Hey, Chuck.
evening, everybody. Hi, Dr. Pressner. Good evening. We'll tell you about our long-standing relationship in just a few minutes. Good evening, everybody. My name is Chuck Cohen. I'm the Managing Director of Benco, and I am the fill-in host for this evening. Our usual host, Kay Huff, had a little minor surgery yesterday, and she's unable to be here. So it's a little bit like sitting in Jimmy Kimmel's chair at late night TV. No matter how funny or entertaining you are, you're never quite as good as the real thing. So I know it'll be difficult, but I'm going to try to live up to the standard that Kay's been setting as our hostess for these webinars since March, since COVID hit in March. So welcome, everybody. It is now just about 7 o'clock, and our participants are filing in. While everybody's getting ready for tonight's program, I would like to read a few introductory remarks about the CE element of this class. So this is a 1-hour continuing education program presented by Benco Dental. A couple things you need to know if you are going to get the CE credit. Please use your legal name on your license to register. So if it says Joe, it should say Joe. If it says Joseph, make sure you register as Joseph so we can easily find your information and send you the CE credit. Every person must register separately, with each person using their own name and their email address. So if you're watching on someone else's computer, please log off and get on your own, or else we cannot grant you CE credit. You must be logged into the webinar with your own device. If you're logged in only with a phone, all we see is your phone number. So please email, it's okay, but please email your given name that's on your license and your phone number to our email address, practicecoaching@benco.com. That's practicecoaching@benco.com. So we can match up your phone number with your information. We do check to make sure that you watch all the way through the end in order to receive the CE credit. So please don't stop in the middle. Stay all the way to the end. After the course, you will receive a survey with your CE certificate. Please complete the survey. We'd like to know some feedback on how we did. There will be Q&A at the end of the session. At the bottom of your screen, you should see a Q&A button. Please click on that and then enter any questions into the Q&A section, and we'll get to them either during the program or right afterwards. If we have too many questions for Dr. Pressner to answer before the end, he will give us some typed answers, and we will circulate them all to everyone who participated. And please stay in touch. Share a picture with us of you learning, having fun with your team, family. These programs have become regular occurrences for some people, so we love to know how you're doing, and we love to get feedback on the survey afterward. So with that, we'll get started with this evening. We have over 50 attendees already, so I'm going to read you Dr. Pressner's bio, but then I'm going to talk a little bit about my relationship with Dr. Pressner. So this evening, Dr. Pressner, Saul Pressner, is talking about how to preserve teeth. It's minimally invasive dentistry with the biomimetic theory. Dr. Pressner has been a devotee of the biomimetic school of thought in dentistry for about a dozen years. He's a graduate of Penn Dental Medicine, and he did a 2-year family dental residency at UConn. He's also got a lot of initials after his name. He's a fellow in the Academy of General Dentistry and the past president of the Academy of Biomimetic Dentistry. He also has a practice on the Upper East Side of Manhattan. So that's where we first met. About 30 years ago, when I was a young rookie sales rep for Benco, walking in the streets of Manhattan carrying my heavy bag, I happened into Dr. Pressner's office. He was in a different location then, but he was exceedingly nice and patient and put up with me. And so we go back 30 years, which is not a long time if you say it fast, like this, 30 years. I'm proud to say that we both look as good, maybe even better today than we looked back then. Dr. Pressner is Dr. Pressner is a long-standing Benco customer. He's also, and I can say from personal experience and conversations with him, he's an excellent dentist. He really understands the art and the science of dentistry, which I'm sure he will talk about tonight as he talks about biomimetic dentistry. So with that, Saul Pressner, the floor is yours. Thank you for sharing your wisdom with us this evening, and please go from here. Nice to meet you again. Good to see you again.
Okay. Thank you so much, Chuck. It's really a pleasure to do this and to have you as my host. So thank you, and thank you to Benco for allowing me to have the opportunity to speak tonight. And thank you all for joining us. A few of my classmates from Penn and friends from Penn are here, so thank you guys. And so I'm here to talk about biomimetic dentistry, tooth-preserving biomimetic dentistry, specifically in the age of COVID-19. And I don't know about you all, but it's been tough coming back. Just all the new protocols. I mean, we're all familiar with infection control, obviously, many of us since the AIDS crisis, but this is a little different just because patients are very uptight in general and our staffs are uptight. So I'll try to give you a little guidance from what I know, and hopefully we'll have some fun and learn something tonight. So here we go. That's just a picture of my Penn Dental reunion last year in Philly. A number of these people may be on the webinar tonight. We had a great class at Penn, and I'm eternally grateful for having gone there. It's just a great dental school, and I've made some great friendships through that. So I thank you all for being here tonight. So biomimetic dentistry really literally means mimicking life in dentistry. We try to restore the tooth to its natural state with various biomimetic protocols, materials, and techniques, which I will go into tonight. And we're trying to save as much healthy tooth structure as possible. When I was in dental school, if a tooth cracked, we were likely to prepare the rest of the tooth for a full coverage restoration. But with modern adhesive technology, there is a lot less need for that now than there was back then. And again, we, as dentists, we all strive to do no harm. And I personally feel, and in my experience, by using biomimetic dentistry protocols, we're doing the least amount of harm we can to restore tooth and to the patient, because through these protocols, patients can hold on to their teeth for longer. And we're trying to do what's in the best long-term interest of the patient. And in my experience, if you do that, things usually work out well. And also, especially in the age of COVID-19, I don't know about you guys, but I'm trying to get enough sleep, good exercise, which is challenging without a gym, but I do yoga and I meditate and I have some light weights at home. Try to have a good diet, and I'm just trying to be open to new ways of thinking since we have been exposed to a lot of new ideas during this time period. But as a dentist, as we all know, it's a very stressful profession. I think it's more stressful now since our patients are even more stressed. So we have to take good care of ourselves primarily so that we can take good care of our patients and our staffs and our families. I have no financial interest in any of the companies or individuals presented in this lecture. And as Chuck mentioned, please feel free to ask any questions you would like. And any questions we can't get to, as Chuck said, please feel free to email them and I will answer them as soon as possible after today's lecture. It may take a day or two, but I will get back to you all as soon as I can. And this is just a picture of the Trudy Berger Dental Clinic in Jerusalem where I volunteer. Unfortunately, I wasn't able to go there this year. One of my friends who's watching this volunteered with me last year. She went to Penn with me, but due to COVID-19, I was unable to go there this year. But you know, we're lucky in dentistry to be able to have a skill where we can give back. So this is just one of the opportunities that I use to give back to our fellow human beings, and that's the website. If you are interested in eventually volunteering there, it's a great clinic. It treats the needy, young and old of all faiths, which I find very compelling. It's a great model for other organizations in Israel. And that's just a picture of me treating a patient there. And I really love doing it. And I missed it this year, unfortunately. So. Okay, so Ray Bertolotti, who is one of my main mentors, as I was telling Chuck before we started tonight, he really was responsible for bringing dental adhesive concepts to this country about 30 years ago, about when Chuck and I met. And he talks about tooth preservation versus tooth amputation. And in preparing for this lecture and for some others, I gave a lecture at Penn actually in late February, the last time I ventured out of New York City. prior to the pandemic. And prior to that lecture, I asked Ray, among other of my mentors, what the salient points would be that I should convey to my attendees in these lectures. So what he said to me is that let's change our way of thinking from mechanical retention, which was the classic GV Black form, to adhesion. And we have the materials and the techniques to be able to do that now. So I just want us to change our paradigm. We don't have to worry about undercutting walls to hold in an amalgam anymore. We can have more parallel or divergent walls and rely upon adhesion and reduce less healthy tooth structure and preserve more healthy tooth structure. And therefore, it's more likely that that tooth is going to be around for a longer period of time in the patient's mouth. And in biomimetic dentistry, peer-reviewed studies strongly suggest a relationship between the greater amount of tooth structure remaining, and I should say the greater amount of healthy tooth structure remaining, and the better long-term prognosis of that tooth. So we're going to go through various techniques where we accomplish this: layering, minimizing the C factor, eliminating MMPs, going through various bonding techniques such as total etch, which is now called etch and rinse, self-etching primers. We use polyethylene fiber, and I'll go through final restorative options as well. And another advantage of using biomimetic techniques is that we minimize periodontal inflammation because we try to remain supragingival whenever possible. When I was in dental school at Penn, we were taught to vary the margin when we do a full coverage crown. That's not necessary with biomimetic dentistry. We can be supragingival, still maintain a nice aesthetic result, and we can have less gingival inflammation as a result of that. Now, interesting, when I gave, I've given 3 lectures at Penn, my alma mater, and the head of restorative dentistry there said at the beginning of my first lecture a number of years ago, the minute you take a handpiece to a tooth is actually the beginning of the destruction of that tooth. Think about it. We have to be mindful when we're preparing teeth. We want to maintain the healthy part of the tooth and remove the diseased part of the tooth. Because the more healthy tooth structure you remove, the more likely it is that that tooth will need root canal therapy. The more likely it is that if you do a root canal in that tooth, you're going to potentially have a catastrophic fracture of that tooth. The patient will lose the tooth. You'll end up with an implant. And implants don't always work. They're not the panacea that we've been told they are. Peri-implantitis is a reality, as you probably already know. So the best bet, in my view, and the major takeaway from this lecture, if you take anything away, is to try to preserve as much healthy tooth structure as possible so that the patient can hold on to that tooth for as long as possible. We're all living longer, we're living healthier, hopefully, and we want to maintain our teeth. And you're doing a great service by doing the least amount of harm by preserving the most amount of healthy tooth structure you can. And I just want to go through a video that illustrates this. Some of you may have seen this before, but it's a good reminder about what can happen when you're not minimally invasive. It's called The Cycle of Tooth Death, courtesy of Drs. Pascal Magnier and Matthew Najad. They both teach at USC in Los Angeles. Here we go. So as you can see, here's a typical class 2 carious lesion. Innocent enough. In traditional dentistry, like when I was in dental school, we were taught to prepare an amalgam preparation here, undercut the walls to retain the amalgam, and get rid of the decay, get rid of the carious tooth structure. But what you may have seen in practice is a cusp breaks because of the undercut walls. So when that happens, we've been taught to now prepare this tooth for a crown to quote unquote protect the tooth from further damage. But when that happens, often you end up with the tooth needing root canal therapy, or sometimes even prophylactically do a root canal. We've been taught to do a dowel, a metal post and core to retain the crown. And what can happen, unfortunately, with that over time is you can get a catastrophic fracture down at the tip of the root. And when you get a fracture like that, lots of luck. You know, unfortunately, you can't repair that. And then you're ending up with an implant. And as I said, implants don't always work. If they do work, you can end up with complications such as peri-implantitis. And it all started out, the moral of the story, with a class 2 cavity lesion. So if we can solve that problem more simply and less invasively, we're better off and the patient is better off. And that's the moral of that story. So for example, here, this is an example of a conservative tooth prep design. You can see the walls are more rounded. This is a slide of Dr. Simone Della Peri, one of my mentors who practices in Sardinia. And you can see the walls are divergent and rounded. There are less stresses on these remaining tooth walls of this class 2 cavity prep. You could even probably do it even more conservatively now with air abrasion. And in this case, again, rounded line angles. You try to avoid sharp line angles. And I'll show you how such a restoration is built up gradually with increments, minimizing C factor, minimizing the stresses within the developing polymerizing composite. Another example, this is one of my teeth, one of my patient's teeth, I should say. I always try to use a rubber dam, especially in the age of COVID-19. And again, try to keep it conservative, rounded line angles. Isolate it, put the matrix on. And then we just fabricated a conservative stress-reduced class 2 composite restoration. So here are just some of the benefits of biomimetic dentistry. We try to conserve more pulps. We remove the pathology. We leave the maximum amount of healthy tooth structure. It can actually strengthen teeth. And we stop the retreatment cycle. Like in the video I was showing, you go from one treatment to another when something fails. If you have an amalgam with undercut walls, you get a fracture, you end up doing a crown, root canal therapy, a post, the whole 9 yards. So we try to interrupt that, and we have a different paradigm. We try to repair restorations. We don't have to have the ideal restoration and have the tooth lost. And we can also repair fractured teeth. We can repair fractures themselves. We can also build up fractured teeth in a more tooth conserving manner, which I will go into. Just a picture of my dad, who is 98 and a half. I'm hoping to bring him out on the links a little bit more this summer. With COVID, it's been a little more challenging, but we'll see. And I hope I have his genes, because as I told Chuck, I have a new office and I want to be here for a long time. This is just an example of what can happen when you have a crown preparation. This is not my patient's tooth, but this is one of my mentors, Dave Alleman's patient's tooth. And evidently, the patient walked into Dr. Alleman's office one morning with a crown in his hand and said, "Doc, can you just re-cement this for me?" But the problem was, most of this tooth structure was within the crown itself. So when it comes to this situation where you have very little tooth structure left to work with, you're left with the choices of crown lengthening, building up the tooth again, or extracting the tooth and doing an implant. So if we can avoid this situation to begin with by being more tooth conserving, avoiding the root canal hopefully, and just if things break down, we can repair them. The patient still has his tooth. That's the moral of the story. This is just a neat slide by Dr. Tim Rainey, who practices in Texas. He used air abrasion in this extracted tooth to show you that he maintained these so-called Rainey ridges, and it maintains more strength within the tooth structure rather than creating a very large class 1 cavity. And this is another example of that same concept by Dr. Simone Della Peri, who I mentioned previously. Leaving this little ridge, you can bond to these dentin and enamel walls and maintain more strength within the tooth substrate. And in biomimetic dentistry, we're trying to reduce the stress within the polymerizing composite. And by doing that, that increases the bond strength of the restoration to the tooth with various biomimetic protocols. By increasing the bond strength, we are better able to maintain the peripheral seal and prevent bacterial ingress at the margins. By maintaining the seal, we lessen the likelihood of infection and fracture of the tooth, and this maintains the viability and the longevity of this tooth. So that's what we're striving to do. This is another example of my friend Dr. David Alleman, who again practices in Utah as one of my mentors. I'm going to show you some of his other cases as well. And you could, when you do a full crown prep, you have to be mindful of how far you are from the pulp. And in this case, it was a deep chamfer and the nerve died and root canal therapy had to be performed. So we're just trying to avoid this scenario by being less aggressive and more conservative. And this is just a really good slide by Unterbrink and Liebenberg from 1999 about what the adhesive equation is. Adhesive dentistry could best be expressed as a simple relationship between bonds and stress. If the bonds can withstand the stress, the restorative technique will be successful. So in biomimetic dentistry, we seek to minimize stress, and therefore we can have a stronger bond between the restorative material and the tooth substrate. And these are just two concepts I'll go into in biomimetic dentistry: the caries removal endpoint and the peripheral seal zone. I will go into that in more detail shortly. These are just some techniques we use in biomimetic dentistry. We try to strive for an ideal caries removal endpoint and peripheral seal zone. We strive to deactivate MMPs. We use air abrasion, which I'll show you. We bevel the enamel. We use gold standard dentin bonding systems. We do immediate dentin sealing on indirect restorations, which I will go into as well. We resin coat the dentin because, as I'll show you, the dentin bond takes longer to mature than the enamel bond. And we do deep margin elevation to isolate the gingival margin so that we can have a successful seal at the gingival margin of a restoration. And before we start on working on a tooth, it's very important to evaluate the occlusion. We want to be aware of the occlusal pattern, eliminating plunger cusps, non-working interferences, and we strive for cuspid protected occlusion. It's also very important to vitality test to make sure that the tooth is vital before we start, because there's a decision tree to be made. If the tooth is non-vital, then obviously the tooth will have to have endodontics if we're going to save it prior to our treatment, if at all possible. And these are just some techniques we use in biomimetic dentistry to relieve polymerization stresses. Indirect or semi-direct restorations are good at that. And we decouple the dentin bonds with time. As I was saying, it takes a while, more time for the dentin bond to mature than for the enamel bond. We use low C-factor increments if we're doing direct composite. We use polyethylene fiber, slow start curing protocols. We onlay thin cusps if we have to. And we use low shrinkage materials. And we also use self-cured materials when we can. And these are just some of the goals that I've gone into already a little bit. Early treatment and early diagnosis. We try to preserve pulp vitality. This is repetitious. You get the idea. And we try to use materials with similar moduli of elasticity to that of tooth structure. And that's just the definition, which we probably all know, of the modulus of elasticity. And that's just a table showing various materials and areas of tooth structure and their various moduli of elasticity. And we try to reduce MMPs, as I said. I have this product, but there are other products that do the same thing. And I do use polyethylene fiber. And the reason I use polyethylene fiber within composites is it's very effective, as studies show, of reducing the C factor, which is the ratio of bonded to unbonded surfaces. And we try to maintain a low C factor in our developing polymerizing direct composites, because by having a low C factor, we limit stresses around the surrounding enamel and dentin walls. And this rib-on fiber net also, supports thinner weak cusps, and it causes less stresses to develop in the curing process of the final direct composite restoration. And polyethylene fiber also can stop, inhibit, and redirect cracks and bridge cracks. I will show you some cases of that of my own later. That's just what it looks like. And here's fiber being placed in a cavity. Before doing this, we selectively etch the enamel with phosphoric acid. And I use a dentin bonding system. So we prime the dentin and bond the dentin, place a very thin layer of flowable composite, and I coat the fiber with unfilled resin prior to placing it in the cavity. That's just showing it being placed within the cavity. We try to place it as close to the pulpal floor as possible, and I'll show you why. I'll show you some studies that show that that is a very important thing to do, and why. That's just placing the fiber. This layer, this is not my slide, this is from Dr. Alleman, but the layer of flowable should be thinner than that, trying to place the fiber as close as possible to the pulpal floor. And again, another concept with the fiber is that you want to make sure the fiber is embedded within the tooth structure and restoration. You don't want the fiber too close to the cavo surface margin, because if fiber extrudes, it's a source of contamination and it can cause bacterial leakage into the restoration and recurrent caries. And this polyethylene fiber can also be used for root canal treated teeth to build up an adhesive biomimetic core that mimics the flexure of the root. It's very close in properties to the surrounding internal dentin walls. So less stresses are created within the surrounding tooth structure, which can result in less fractures potentially of that tooth. Here's just an example of one of my cases. You can see a vertical crack using a rubber dam. Dr. Robbins from Penn would be very proud of me. So here's a crack, and this is an endodontically treated tooth, obviously. So what I did is I selectively etched the enamel, primed and bonded the dentin, placed a layer of flowable, and then the rib-on bridging the crack. And then we gradually built up the biobase, or buildup, in increments, horizontal increments. And this tooth did eventually receive an onlay because I felt that the walls here were thin and I did not want to just rely upon the fiber, excuse me, and the composite for the strength of the tooth. Excuse me. This is just an example of a structurally integrous tooth. You can see no cracks or infection into the dentin. And here you can see a tooth that is a problem. IRM here, a fracture in the amalgam, fracture of the cavo surface. This is a case of my mentor, Dr. David Alleman. We've got problems here. So what he did is he removed all the amalgam, removed the IRM, and he used caries detecting dye to stain the infected dentin. You've got to remove the infected dentin because if not removed, that can spread and cause pulpal damage. But I'll show you some other cases. You want to leave the affected dentin. You can bond to the affected dentin strongly enough so that you have a good peripheral seal and you can maintain pulp vitality. The bottom line with this is you want to remove the infected dentin, relieve affected dentin so you can avoid exposing the pulp. When you expose the pulp, you're going down a road which can lead to the ultimate loss of that tooth. There's a great paper by Van Thompson and Ron Craig, which goes into this. I have the reference. I don't have it in my lecture. If anyone wants the reference, I can get it to you in the next few days. That shows you're better off leaving very deep affected dentin and not exposing the nerve. And that's the final restoration. You can see here, you can see it's supragingival, so less pulpal inflammation, and he did a nice Emax onlay here. Instead of doing a full coverage restoration, which would have resulted in more loss of healthy tooth structure and potential gingival inflammation. Here's another case of his. This is infected dentin, okay? Very near the pulp. He avoided an exposure. This is affected dentin. If you use caries detecting dye, you see like a little pink haze here. You leave that. you can bond to it. And then what he did is he selectively etched the enamel, primed and bonded the dentin, placed some thin flowable composite, ribond, fiber, polyethylene fiber, I apologize. And this fiber lowers the C factor. And this polyethylene fiber ribbon, by lowering the C factor and decreasing the stresses in the polymerizing composite, results in less stresses in the surrounding tooth structure and in the developing polymerizing composite. What he did here is he divided, as he was placing this composite in horizontal layers, he divided them so that less stresses will be developed during polymerization. And that's the final restoration. Stress-reduced direct composite. So just a few slides about where biomimetics started. Chuck was asking me this before. Dr. Takao Fujiyama really developed the total etch and rinse technique, and it was brought to this country by Dr. Ray Bertolotti, as I mentioned. Dr. Didier Dice in Switzerland has also been a big proponent of tooth-preserving biomimetic dentistry. And Dr. Pascal Mann at USC as well. And Dr. Dave Alleman, who I recommended. I've taken courses with Pascal and Dave Alleman and with Didier Dice. They're all excellent for advanced knowledge. I would highly recommend further training with any of them. And this is an interesting slide. You can see a fracture that goes from the enamel into the dentin. You can see caries here. This is occlusal effect caries due to a crack. It's not from lack of flossing. It's called a peripheral rim fracture. So when it comes to a case like that, you have to intervene, because if you do not, you're going to be ending up with a pulpal problem. And this is just the concept of the biorim, which we have in biomimetics dentistry. Again, we try to leave 2 to 3 millimeters of cervical enamel, DEJ, and superficial dentin for best restorative success, according to Dr. David Alleman. And this is just the structural analysis which we do when we have a crack into dentin. We measure the width of the isthmus, the thickness of the cusps, and the depth of the proximal box. And these are just all contributing factors we take into account when we're doing our treatment planning for our biomimetic restorations. This is just a paper by Opdam, Frankenberger, and Mann in operative dentistry, which is a very good paper which shows some of the reasoning behind being more tooth conserving. And the main takeaway I'd like you to have from this is that crowns have limited indications. They are indicated in replacing existing crowns, implant restorations, or abutments for bridges, or where it's too difficult to place a direct composite. Minimally invasive is best, according to this paper. And if you use your common sense, by taking away less tooth structure, you're less likely to get into a pulpal issue, and you may get into a repair issue down the line, but the patient still has his tooth or her tooth. So that's the bottom line in my opinion. This is a very good paper by Drs. Alleman, and Najad about the protocols of biomimetic dentistry in Inside Dentistry, June 2017, if you're interested in learning more about these techniques. Immediate dentin sealing by Pascal Mann et al. In JPD in 2007. The takeaway from this is that when you're doing an indirect restoration, either by a scan or an impression, by doing immediate dentin sealing prior to the scan or the impression, you get a better bond strength of the final restoration to the dental substrate. And this is just the C factor I spoke about earlier, the ratio of bonded to unbonded surfaces. And a low C factor is more favorable, as I said, to reducing stress in a restoration. And that's the reference for that, 2003. And that's just the definition of a biobase. It's basically a buildup in conventional dental terms, but that's what we do in biomimetic dentistry. And we try to reduce the C factor. We use layering techniques in biobase fabrication to minimize the stresses to the surrounding tooth structure. We want to minimize stresses in biomimetic restorations. And by doing that, the restoration is more likely to succeed and the tooth is more likely to be with us longer. And this is just an example by Dr. John Durango, a colleague of mine who actually presented at one of my biomimetic meetings a number of years ago. And he used a polyethylene fiber in some abfraction lesions. So you can see these are the abfraction lesions, and many of us may have had similar cases, and sometimes they fall out. But what he found is by using a technique of etching the coronal enamel, priming and bonding the dentin, and placing a little flowable, and placing the fiber, after 3 years, none of these restorations were lost. And I will go into that technique a little later in a paper that's being done to follow up this study at University of Washington Dental School, where I'm actually giving a presentation September 12th with some of my colleagues. Just a picture of you guys from Penn. You may recognize him, Alon Waldinger. He's a classmate of mine from Penn, and I see him whenever I volunteer in Israel. So a little word about biomimetic dentistry and COVID-19, which unfortunately is our new reality. So in biomimetic dentistry, the CDC has given guidelines, as we probably all know, about minimizing the number of people in the waiting room and having more time intervals between patients. They're also trying to convey to us to take care of the matter at hand, the problem at hand, and create less aerosols, less chair time. They really want us to treat the problems that are most acute so as to minimize the patient's exposure in our office, minimize our staff's exposure, minimize our own exposure. So biomimetic dentistry, I think, really dovetails very nicely with this approach of the CDC to try to be more minimally invasive to treat the problem at hand. I don't know about you guys, but I don't think we're going to be doing a lot of full mouth reconstructions right now. People are scared. They've been affected by this financially. We want to take care of our patients in the best way possible and try to help them. And I think biomimetic dentistry is very well positioned and suited to do that. More use of the rubber dam, using air abrasion with suction, using high-speed suction, as I mentioned. And again, repair versus retreatment. We try, if we see something that can be repaired expeditiously and effectively, that may be the best treatment at this time. Usually less risk of tooth loss this way. It's more cost effective for the patient. And I've actually found it to be a practice builder through word of mouth referrals. Patients like it. It's less uncomfortable, less anxiety producing. When you use air abrasion, there's less noise and less discomfort. So just an idea to consider. And, you know, again, patients are worried about going into the dental office anyway, and before COVID-19, but now they're even more queasy. So I would just advise being very empathetic, trying to treat conditions more conservatively. And I really feel patients will appreciate this approach. That's my take on that. And I would also recommend reaching out to patients and staff to reassure them of the safety protocols and have them have more comfort about what we're doing, so that when they come in, answer any questions they have, take time to talk to them on the phone. Look, it's their lives, it's our lives. We want to do the best we can, again, to do no harm. And that's just, that mirrors the same thing. I took a seminar from an Israeli marketing consultant during COVID-19, during one of my many hours free when I wasn't treating emergencies. And he basically said the same thing. Try to be minimally invasive and deal with the problem at hand. So we're going to get into some case studies. This is a case of mine where the patient unfortunately had cervical resorption, external resorption, from multiple rounds of ortho. So the concept to take away from this is that patient had crown lengthening. I did a cervical composite using deep margin elevation to isolate the gingiva. So we did a restoration down there. And then, since in this case there was resorption, external resorption cervically, I ended up doing a gold onlay, but the margin of this restoration is discrete from the margin of the cervical composite I did. Rather than do full coverage, I did 2 different restorations here. And I also did this because he's a bruxer and it wasn't in a visible area. So in biomimetic dentistry, rather than preparing this tooth for full coverage, taking down a lot more healthy tooth structure, I was more tooth conserving. Patient still has a tooth. And just an example of some incisal wear from bruxism, which I restored conservatively with a direct composite and a night guard. Another case of a 35-year-old female. She had root canal therapy. She preferred not to have a crown and wanted to preserve as much tooth structure as possible. These people find me. They can find you too. So the root canal therapy was performed. A pulp chamber base was left for me to do my biobase. And as you can see, she must have a tetracycline stain. She was not happy with the appearance, but I did a biobase with fiber and a gradual buildup of composite. That's what it looks like. Again, unhappy with the appearance here. So instead of doing full coverage, I did a direct composite on the facial and the buildup internally on the occlusal. And she was happy, and the tooth is surviving fine. Just an example, another patient of mine, he had a PAP, a cellulitis. I did an IND, I did the endo myself, and you can see periapically it healed. And then when restoring the tooth a little while later, the periapical that I just saw was taken out of sequence. That was taken months after I did the restorative. But I wanted to show I was proud of the fact that it healed periapically because it was my endo. Anyway, what we did to restore this, selectively etched the enamel, primed and bonded the dentin. This is the resin coating. We allow the dentin bond to mature. We build up the enamel skeleton here because the enamel area matures first. That's the enamel skeleton being built up before we build up the dentin replacement. Now, after 5 minutes of maturing for the dentin bond, we build up the dentin replacement, isolating it, as you see, under a rubber dam. I did an Emax only, which is not pictured, unfortunately, but it's fine. He moved to San Francisco, referred him to one of my colleagues, one of my biomimetic colleagues out there. And teeth having certain types of fractures, particularly posterior teeth that have been treated endodontically, may need occlusal protection when being restored, and that one is one that did. And I'm just defining a fracture as a break in the enamel and or dentin, which in certain cases can lead to a complete separation of tooth structure, that in certain cases can lead to a catastrophic failure and tooth loss. In biomimetic dentistry, we're trying to avoid that scenario. These are just some etiologic factors of dentin fractures, which you can figure out. And as I said earlier, traditionally with cracked teeth, we did full coverage. We don't have to do that anymore. That's just the way we can diagnose fractures with magnification, air abrasion, and caries detecting dye. And in vital teeth, symptoms of fracture may include sweet and cold sensitivity, chewing sensitivity, mostly upon release. Those are just the various types of fractures. And this is an enamel fracture where we don't have to do anything. There was no pain. Here's a crack into the dentin, and we do have to intervene there. Just when we're chasing fractures, we have to be mindful of how far we are from the pulp. If you get, the moral of this story is, if you have a fracture in a tooth and you're getting close to the pulp, you know your distance based upon your tooth anatomy, you can stop close to where the pulp is and not expose the nerve, and you can actually bridge the fracture with fiber. Again, over cusp tips, be mindful of how far you are from the pulp. Again, you want to avoid a pulp exposure if at all possible. This is a case of one of my mentors, Graham Milicic. You can see this tooth had endo. He ended up leaving this area of tooth structure because if he did a full crown, he'd be taking all of this away and taking away a lot of the occlusal tooth structure as well. And it would not be as aesthetic as well. So I'll just through this quickly of how he restored this tooth. Isolation. You can see gradually building up the core with fiber and composite. And that's the final result. Patients are a lot better off having their own natural tooth structure on the outside rather than worrying about gum recession from a crown and shade matching. And that's the final result, final restoration radiographically. Again, you got to use magnification, caries detecting dye, air abrasion. Here's one of my cases, fracture in the amalgam, isolation under a rubber dam. I explored the fracture as much as possible, selectively etched the enamel, primed and bonded, and I bridged these cracks here with the fiber, gradually building it up. And as you can see, I separated the two polymerizing segments of composite using horizontal layers of composite to minimize the stress. And that's the final composite restoration. I'm gonna go a little quickly. I don't want to run out of time. PAP on this case, endo was performed, isolation, removal of any caries remaining, bio-based buildup. Here I did an Emax onlay. Sorry for the fogginess of the slide, but you can see it's supragingival and minimal gingival inflammation here, but I did onlay the cusps here. Another case, PFM, endo was done through the crown, but the crown looked okay radiographically. On recall, I noticed a vertical fracture here on the mesiolingual. What do? Do I remove the crown? I decided not to. There was no gingival inflammation nor evidence of a pocket here. I air abraded the fracture, primed and bonded it, and repaired it with flowable composite. It's been 3 years and no pathology, and the tooth's been fine, being minimally invasive. Case the same. This is the same case of the lady with the Emax onlay. She broke off her lingual wall, amalgam here. I ended up just air abrading it, etching, priming, and bonding composite to it. Tooth's been fine. And that's just why we use air abrasion for caries removal, creation of more surface area, and surface cleaning of the enamel and dentin prior to priming and bonding. It's a case of Simone Della Peri from Sardinia. Broken down tooth, typically you do a cast post and core and crown. But what he did here, built it up with fiber and composite. And it's a beautiful result with fiber and composite. Minimally invasive tooth conserving biomimetic dentistry. Case of mine, 2 bombed out teeth, 6 and 8. These teeth are gonna go, but we needed a transitional restoration. So I ended up priming and bonding, placing fiber, and I built a quote unquote fiber reinforced composite bridge with a pontic. It's aesthetic, functional until he's ready to go for implants. Again, a posterior composite, fracture present. This composite was okay. I just basically air abraded the fractured area, etched the enamel, primed and bonded it, placed the fiber, and placed a direct composite. An old full coverage restoration which kept falling out, which I didn't do. I ended up doing something different. Selectively etching, removed the composite from 28, which was faulty, primed and bonded, flowable, placed some fiber from this 29 to 28, and built a kind of resin fiber bridge, which he's maintained for about 4 years with a proxy brush. His hygiene's immaculate. I've just had to repair it a few times at the margins. And this is one of my friends from college. His tooth, his dentist told him to take this tooth out. He knows I save hopeless teeth. I figured I didn't have anything to lose. And not ideal, but he still has a tooth like 3 years later. And he's my buddy, and I wanted to try for him. PAPs, tooth needed endo. The endo's done, but he never came back for restorative for 2 months. And lo and behold, I isolated it under a rubber dam, big fracture, but the segments were not moving independently from one another. So he was going to Israel again that night. I isolated it, air abraded it, etched, primed and bonded, flowable, placed fiber, crisscross, and reinforced the cusps. Did a direct composite buildup. That's the result. I removed the flash. 2 weeks later, he's back. He's got a furcal involvement. So what I did is I did scaling and root planing and minocycline spheres, and he got some bone fill. We're monitoring it. So far, so good. Just a garden variety fracture of enamel and dentin, primed and bonded, incrementally placed the composite, and that's that. And here's a case of another fracture, selectively etched, primed and bonded, placed the fiber. You can see pulpal floor and circumferentially building up the biobase. And here's the final restoration. Here I felt there was enough buccal and lingual wall not to onlay these cusps. For the moment, it seems fine. Just another garden variety, similar case to what I've shown you before, building up the enamel skeleton, and then that's the rough restoration. And here is, we're almost done, just about 5 more minutes. For Dr. Ali Reza Sadr, one of my mentors at University of Washington, who I'm speaking with in a few weeks on September 12th. And he's doing some really groundbreaking work with placing fiber in the pulpal floor, as close to the pulpal floor as possible, of composite restorations. And what he found is in restorations where he's placed this polyethylene coated fiber, he finds less pull away of the restoration from the pulpal floor, which can translate into less sensitivity and less caries and less pain. And a longer duration restoration. So he's working on another study of that as well, which is this one right now. So stay tuned. And just to sum up, in biomimetic dentistry, we try for partial coverage if feasible, less risk of root canal therapy. It's usually more cost effective. It's generally less invasive, and partial coverage often means supragingival margins and better gingival health, if we can. Just some fluorescence products, which can replace caries detecting dye eventually. Another antibacterial composite that's going to be on the market. And these are just some of my mentors in biomimetic dentistry. And we use DENTIN bonding systems, as well as enamel etching. Just wanted to especially thank some of my mentors. And that's my dental academy, which I'm past president of and future president-elect of. Again, they wanted me back. And again, studies show it's just best to preserve pulps and conserve as much tooth structure as possible. And by doing this, we're striving to meet our obligations as physicians of the oral cavity and striving to do no harm. And those are just some other references you may be interested in biomimetic dentistry. That's my contact information. If you would like to email me or call me, I'm always available. If I'm with a patient, I'll have to call you back, but I will get back to you. And that's the ABD, my website of my academy. We're giving some informative webinars coming soon. And I want to thank Benko and Chuck Cohen for inviting me. I really enjoyed it. I hope you did too. And I'm open to questions. I tried to be on time, Chuck.
Saul, you did an excellent job as always. Thank you very much. So we do have 2 questions. Let's make sure we get to them before we sign off. The first one is someone, Dr. Alfred, I assume it's Dr. Alfred Warren asked, what about air abrasion and aerosol? Doesn't air abrasion create more aerosol, which then becomes an issue in a COVID-19 world?
That's true. But if you use high-speed suction very close to it very carefully, and I pulse it, yes. But unfortunately, you pick your poison. I don't know what to say, but it is more minimally invasive. It's quicker. You often don't have to anesthetize. But if you use one of those big suction units or your regular high-speed suction, or you use 2 suctions, you try to minimize it as best you can. Nothing is ideal.
One of the secrets is to make sure you've got an assistant who really knows how to use that high-speed suction. A lot of things can be fixed through a good suctioning technique. So thank you for bringing that in. And aerosol is an issue whether you're using a handpiece to cut a tooth or air abrasion.
Very true. I agree.
The other question is, how do you use transillumination in your care to see the extent of a fracture? Asks Dr. Oro, Dr. Robert Oro.
Hi, Dr. Oro, my classmate from dental school.
Yes.
I use it sometimes, and I think it's very effective, Bob. I agree.
Excellent.
Yeah, I think it's good. Thank you for asking that.
He
And
wanted
thank
to
you
show
for
he was paying
watching.
attention. He wanted to show he was paying attention the entire time.
Didn't
Just
fall
like back
asleep.
in just like back in dental school, I'm sure Bob Oro was the guy falling asleep. He just wanted to show that even 40 years
Star,
later, he was
as
paying
is his
attention.
wife Debbie. They were both my
There you go.
classmates, so I love them.
Excellent. Well, Dr. Pressner, thank you very much for this evening. You were terrific as always. Biomimetic dentistry is an interesting topic and especially timely in these days of COVID-19. So with that, we say thank you very much. We would like to give a little plug for the programs we have coming up. So if you'll move the slide. We do have some upcoming webinars. If you hold your phone to the QR code on the slide, you'll go directly to our website. We do have a complimentary webinar every Wednesday. Let's quickly review some of the programs we've got coming up. Next slide. So on Wednesday, September 2nd, we've got a program by Dr. Gary Light called Freedom from PPOs from 1 to 2 o'clock. That's a free webinar, Wednesday, September 2nd. And then Wednesday, September 9th from 6:45 to 8 o'clock. Fill in the fall schedule with Minal Sampat. I think that's going to address the hygiene schedule in the fall. A lot of dentists are concerned that we're going to see a fall off in hygiene appointments due to the shutdown of dentistry in the April-May timeframe. So Minal Sampat will talk about how to make sure your hygiene schedule is full for the fall. Next slide. Catherine Itel Belt, one of our most popular speakers, will talk about communication skills in the dental practice. Have them at hello. Master and train your teams. Unscripted, exceptional telephone skills. We all know in these days of COVID-19, when safety is an issue, the difference between making a patient comfortable and making a patient a former patient might be the telephone skills of the person you have answering the phone. So this is a webinar, a workshop, I'm sorry, $49 per person, 2 CE credits. September 18th, that's a Friday from 12 to 2, a 2-hour webinar. I am confident that you will walk away from this program with some really solid skills that you and your team can implement in your office. There's an item number 5712-874, or talk to your friendly Benco rep to reserve your place. Thanks to everyone for being here this evening. Thank you, Dr. Pressner, for sharing your thoughts and your wisdom with us. Our email is practicecoaching@benco.com. Your CE credits will be on the way. If there are any issues, please reach out with an email. Have a wonderful evening, everyone, and enjoy the rest of your Wednesday. Thank you. Good night.
Good night. Thank you.